Welcome everyone to today's webinar, RCM Best Practices for Out-of-Network Providers. Today, we'll be discussing how you can optimize your billing and collections with challenging out-of-network payer reimbursements. I'm Christina Donahue, Senior Director of Client Solutions here with CollectRx. Today, I am joined by Franklin Smith, our Vice President of Revenue Cycle Solutions and one of CollectRx's experts in payer collections, to speak with you about what we've seen in 2020 with out-of-network billing and collections and how to ensure that you're being fairly reimbursed by the payers. We'll begin today's webinar with a presentation, and after that, we'll have time for a few question and answer sessions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions, and if we do not have time to cover them in today's session, we will reach out to you afterwards and answer them directly. Today's session is being recorded and will be available after the event. You can use the same link you used to log in to today's webinar to access the recording. At this time, it is my pleasure to start today's webinar by introducing my co-presenter, Franklin Smith.
Thanks, Christina. We're excited to join you today and share some of our experiences in dealing with payers on out-of-network claims. We're going to start out with a quick overview of CollectRx and why we feel we're in a good position to talk authoritatively about payer collections. We'll then give a quick overview of what the data says about 2020 at the macro level, then jump into what some of the unique challenges are that have emerged this year and the best practices to address them. And we'll wrap up with a quick overview of how CollectRx can help you with our out-of-network solutions. So to start, who is CollectRx and why are we in position to talk about payer collections? Let me give you a quick overview of our experience in payer collections and in out-of-network more specifically, so you can see how we are well suited to these trends. Despite our name, CollectRx has nothing to do with the pharmaceutical industry. Simply put, what we do here at CollectRx is help providers get higher reimbursements on in and out-of-network bills and maximize payer collections. We don't do this as consultants, but as experts in negotiation and appealing in order to achieve higher reimbursements on your bills and collections. Founded by the founders of the out-of-network negotiations and appeals industry that started all this stuff, CollectRx has been singularly focused on helping providers get higher reimbursements since 2006. We've helped more than 2,500 providers nationwide optimize their reimbursements for in and out-of-network collections. We work with a variety of provider types, including surgery centers, physician groups, hospitals, and labs. To get the results we get, we rely on CRISIX, which stands for CollectRx Information Systems. This is the proprietary data and analytics tool we've developed to support us as we go toe-to-toe with the payers. CRISIX helps us analyze insurance policies, provides comparative data, and allows us to track tendencies and trends of the people on the insurance company side. In addition to CRISIX, we rely on our expertise. We've built a unique team of experts who used to work for the insurance companies and their vendors. This puts us in a unique situation to understand the soft spots in the payer's position and get higher payments on bills for our customers. In building the team at CollectRx, we focus on hiring people who had worked previously for insurance companies and their vendors to reduce payments on out-of-network bills. Companies like the ones you see on this slide, including Aetna, United Healthcare, MultiPlan, and Valiant. We also have doctors and in-house and outside legal experts, many of whom have spent their entire career dealing specifically with out-of-network bills. And as a result, CollectRx has an experienced team that understands how to combat the tactics payers use to limit our out-of-network reimbursements. So let's start with a recap of what this unprecedented year, 2020, has brought us, focusing on the top issues that are impacting providers. We all know the statistics. Over 200,000 lives this week have been lost in the US alone, with 7 million infected, with many areas continuing to see peaks in their daily rates. Financially, the impacts have been shocking as well. 32% in our gross domestic product has dropped. We've had the US GDP quarterly drop was the worst since the Great Depression. But there are some statistics that are critical for the healthcare industry as well. Phreesia is a healthcare technology company that helps ambulatory practices with the patient intake process. This includes registration, insurance verification, patient questionnaires, patient-reported outcomes, and payments. The data reported here from Phreesia's clients, which include more than 1,600 provider organizations representing more than 50,000 providers across all states. In a typical year, these provider organizations have more than 50 million outpatient visits or more than 1 million visits a week. The graph shows how the pandemic has negatively affected their patient census and how much work loss of volume. At the beginning of the COVID-19 pandemic in March, hospitals and providers largely canceled elective procedures and non-emergency care in response to federal recommendations, as well as state and local requirements to make resources like personal protective equipment and hospital beds available for a potentially large wave of COVID-19 patients. Further, people have been wary of seeking care at hospitals and medical facilities for fear of contracting the coronavirus. The economic downturn and unemployment have led others to postpone care because they cannot afford it. This has raised concerns of poor health outcomes if people do not receive needed preventative care and questions about whether all postponed care is truly needed. Preliminary data have shown that in-person ambulatory outpatient visits and emergency room visits declined during the early months of the pandemic. Yet we know little about medical care after stay-at-home orders were lifted and healthcare practices reopened. By the week of July 16, 2020, about 1 of 3 adults, or 32%, in the US said they needed medical care for something unrelated to COVID-19 but did not get it. This was relatively unchanged over the course of the weekly surveys from April 23rd to July 21st of this year. While other evidence has shown that some healthcare services have rebounded, the proportion of patients who have said that they are foregoing care has not changed, even though health clinics, hospitals, and businesses have reopened. To put these numbers into context, prior to the pandemic, about 8% of the US population said that they delayed care because of costs. As the pandemic has progressed through the summer, it seems the population has been willing to take more chances on addressing their healthcare needs. As the pandemic peaks and increases in specific areas, the negative trend of fewer patient encounters has continued for those specific areas. The difference is the decline has not been as sharp during the summer months in the manner that we saw in March. Most recently, visits to some specialists such as dermatology, ophthalmology, and adult primary care have returned to or exceeded their baseline rates. Visits to other specialties such as pediatrics and pulmonology remain substantially below their baseline. There have been striking differences in specialty visits trends throughout the pandemic, with dermatology had one of the largest initial declines in visits, but then rebounded above their baseline. Behavioral health, which had one of the smallest initial declines, has only modestly rebounded, and with visits plateauing at 15 to 20% below their baseline. So the fraction of all visits per week for self-pay patients, and that is, to define it better, those lacking insurance, has increased over the course of the pandemic. This could be because the number of people becoming uninsured is increasing, or more uninsured patients are becoming ill and are seeking care. In April 2020, in the midst of the COVID-19 pandemic, healthcare professional services declined 68% in utilization and 48% in revenue based on total estimated in-network amounts compared to April 2019 nationally. According to the Fair Health's third COVID-19 study in April 2020, these facts are really just amazing. In the Northeast, the region hit hardest at the time by the pandemic. Professionals experienced particularly sharp drops in utilization and revenue, 80% for utilization and basically 80% in the revenue in April 2020. In McKinsey's Health System Financial Resilience Survey, CFOs and finance executives of health systems indicated that they are expecting a dramatic impact on both operating margin and their cash flow. 30% of the respondents expected their 2020 operating margin would be 20% below forecast, and 15% are not confident that they will have enough days of cash on hand throughout the crisis. In August, employment in education and health services increased by 147,000, but is still 1.5 million below February's level. So from February to April, there was a 17% drop. And even in August, it's down 5% when it's compared to February. The ambulatory healthcare services subsector consists of these industry groups for your knowledge: the offices of physicians, offices of dentists, offices of other health practitioners, outpatient care centers, medical and diagnostic laboratories, home health care services, and other ambulatory healthcare services. Again, citing McKinsey's survey, CFOs and finance executives of health systems indicate that they are focusing on reducing non-clinical workers and optimizing their revenue cycle as their top 5 initiatives to address the long-term financial impact of the pandemic. So as people in the United States continue to stay home and avoid non-emergency medical care in the second quarter, the country's private insurers reap the benefits, with all major payors companies reporting year-over-year surges in profit. It's quite the opposite of the tale for providers, though. We saw revenue slide without lucrative elective procedures. Hospitals have been largely kept afloat by federal relief funding, which has driven some for-profit operators to triple their net income during the second quarter. Centene, Anthem, and United Health all doubled profits or more in the quarter. CVS and Humana also raised their earnings outlooks for the year. So, the same issues we are seeing across the board for payers are amplified because out-of-network is more complex. You're always fighting for what you should be paid, but now if the people that we're fighting are working from home. Increasing net recovery of charges is more complicated in the out-of-network space because you have more records requests and more reasons for denials and underpayments. So more records requests, more denials, more hoops to jump through, with less people to help you overcome these barriers.
Now, COVID has really turned our worlds upside down in so many ways, and revenue cycle was no different. We have been monitoring and responding to trends across all of our out-of-network providers, and this year has added an extra level of complexity to what was already a complex process. So what are we seeing with both our billing and collections clients and hearing from our out-of-network providers that we work with every day for appeals and negotiations? Well, One thing really that is reassuring is that we're seeing very similar trends across all of our out-of-network providers. So we still do seem to all be in this boat together. And most importantly, we have developed best practices to help manage them. So let's jump right in. One of the first and most difficult issues we are seeing is a steady delay in payer processing. The payers ran into many of the same issues that we all did at the start of this. As they moved staff to remote work, they quickly realized their infrastructure was truly not set up for this new work environment that we were all sort of thrown into. The first thing to creep up were hold times. Having to answer calls through your home internet is much different than the connections in the office. So dropped calls, issues with transferring calls to supervisors, everything just became even more difficult. This was really our first glimpse at the technology issues that would plague us for what turned into months. What was happening behind the scenes was even more chaotic. IT staff went home just like we all did. Internet providers struggled to keep up with the increased demand of all of it, and we all do still remember HIPAA, right? The technology struggles were complex, to say the least. Appeals and documentation requests now had to be processed remotely too, but still securely. The payers had to manage their mailroom remotely and provide access to their document systems across a broader network. Some were able to make this transition better than others, and honestly, others are still trying to figure this out. And of course, staffing issues. Now, some of this can be attributed to the workforce simply not having the connectivity to work from home, but in some specific geographic locations, people were getting sick and they were truly unable to work. These struggles caused things to bottleneck on both sides. First, the providers were unable to get their claims questions answered in the same efficiency as before. For example, some payers couldn't transfer calls to supervisors anymore, and we were actually told to just keep calling back until maybe a supervisor answered. And second, anytime a document needed to be reviewed, either because of a document request or an appeal, fewer and fewer people were able to complete that function at the payer. Appeals processing skyrocketed, sometimes taking 4 to 5 months, which is triple our previous experience. This is something that hits our out-of-network space especially hard. Our claims typically have a higher rate of doc requests and underpayment appeals, so sending additional information to payers to some extent is a standard process for us. In order for providers to get reimbursed appropriately, we all need efficient processing times. These delays really put a slow on our cash. So with these exacerbated payer delays, exception-based practices and follow-up are becoming the rule. It now takes more time and effort for each claim, which in turn makes it even more important to pick your battles and understand you simply cannot and should not fight everything. It has always been important to maintain your payer equity by not fighting those claims that you have no chance of winning. And with the current situations the payers are experiencing, this is even more critical. Providers must move away from the work everything policies. 100% of your inventory does not have to have 3 appeals before you move on, and that's okay. Removing these rules from revenue cycle is important. Moving away from the work everything mentality also simply helps you avoid those non-critical activities that are keeping you from focusing on your important claims that drive your bottom line. I know that for a lot of us, this seems difficult at times, especially with our volumes being lower this year and every penny counting even more than it did the year before. But if we continue to throw good money at bad, we end up losing out on those claims that we could actually be successful on and improve our bottom line with. Now, many of us are wondering, how do we know what to work? And that's where technology can come in to save us. The answers are within our data. The first place to really start here is to look at what you typically overturn and receive increased reimbursement on. Quickly, you'll find patterns in things like CPTs, patient insurance plans, and third-party administrators, where you'll have little to no success in moving the needle. Some of those things you can maybe improve on for future claims like CPTs or medical necessity issues, and some things you simply can't. Either way, fighting is a losing battle, especially now when it is also going to increase frustration and take away from those things you can actually improve your bottom line on. The second issue we are seeing, our payers are paying very slowly. Now, you may say that this has been an issue forever for some payers, but under current conditions, we see claims that have no reason for delay paying slower than ever before, even for their initial payments. Across many of our providers, we are seeing aging rates increase, in some cases dramatically. Overall, we are seeing increases of up to 25% as compared to 2019. Now, some of this can be attributed to the surge we saw when certain communities reopened to elective services, while providers were scrambling to treat those patients whose care had ultimately been paused during the shutdowns. But we also saw that across the country, payers lost processing time on those claims that were already in their system before the pandemic, while they transitioned to work-at-home policies. This created instant backlogs. Claims which generally were residing in about a 90-day processing cycle were routinely aging out to 120 and at times even 150-day pay cycle. Correspondence is also contributing to delays in payment. On both the payer and provider side, paper mail has been one of those things that has been a pain point even prior to the pandemic. From the provider side, staff were no longer going to the post office or even the office daily, and were faced with multiple days of payer correspondence piling up at them all at once. Having to access their EHRs to print charts for those payers that require us to submit paper charts, now were only tackled when you made your way to the office, putting extra pressure on staff to get those processed. But ultimately, no matter how hard our teams were working, these documents were going to a mailroom at the payer, who was also understaffed, and the documents quickly piled up. This brings us to our best practice number 2, monitor your collections like a hawk. We must have a way to effectively forecast our cash flow by payer. Although this was always important, during the pandemic, this has become mission critical to the survival of many practices. Not only do we need to understand general cash flows, but we need to understand on a payer level our new experience for payer turnarounds, so that we can more accurately determine what to expect in the bank and when. Like I mentioned previously, each payer really has had a different response to this, and some are doing better than others. For example, some of our payers already allowed you to upload documents and appeals to their portals while others did not. Now, if your receivable is full of those payers that do not, you potentially have a bigger cash delay on your hands. This will be your best tool to communicate with your leaders in a consistent and thoughtful manner. As many of us know, during times of uncertainty like the times we're in right now, cash flow is something that every leader in our organizations can be obsessing over. Consistently communicating expectations and actual cash collections is important always, and especially now. Monitoring your days to pay by payer and comparing it to your historical performances will allow you a clearer understanding of the timing of your cash collections. Knowing your days to collect by payer, your expected reimbursements, and your outstanding receivable by payer will allow you to create meaningful goals not only for your staff, but also to better forecast payments with. Although a lot of this seems out of our control, there are some things we can do to push the needle. We can limit our impact on our days to pay by ensuring that we are processing and responding to all payer correspondence. Having a process for payer correspondence, especially when our staff may not be in the office consistently to open mail, is one of those things that can be easily overlooked but cost us greatly. We must leverage technology where we can, making sure we are extremely vigilant with HIPAA and limiting the printing of records for mailing when at all possible. Backlogs, issue number 3, and they're growing. Now, backlogs are growing all around the revenue cycle. I have often explained the revenue cycle as an ocean with waves. As one part of the process rises and drops, the next one down the line does the same. Revenue cycle leaders must expect and plan for backlogs from all sides for the foreseeable future. These backlogs are being created on both sides. Although every practice and payer are different, we share some of the same issues with staffing shortages due to work from home limitations, as well as actual illness. We are also then saddled with the delays at the payer and the issues that are causing our claims to pile up. Like I said before, so much of this is out of our control, but providers must modify their operations to ensure all backlogs stay under control. Consider this the adult version of whack-a-mole. Now, we have gone over much of the why, so now how do we deal with this? For some providers, vendor support makes a lot of sense right now. Vendors have been operating in a remote space for a long time, and they're aware of how to complete tasks remotely while remaining HIPAA compliant, and they have a track record for doing so. They can be a great resource to leverage while we all divide and conquer. When I go into a lot of different shops, I see all too common payment posting backlogs. Now, having worked in many facilities myself throughout the years, I do understand why this occurs. But we as revenue cycle professionals must make it a priority for us not to run payment posting backlogs. We must stay up to date on these things that are paid, so we are not wasting valuable follow-up time on claims that have already adjudicated. We must post denials quickly so that we can focus on the accounts that we actually need our staff to work. We must also create a strong denials processing methodology if you've not already done so, making sure we have the right people working on the right accounts at the right time. Now, this is another space where technology can make a substantial impact on our operational efficiency. Using technology solutions to drive accounts to employees who need to complete next steps, all while sorting and prioritizing that user's work, not only by balance outstanding, but also like things such as the cases with the highest probability of being overturned for additional payments are all too important. Monitoring our inventory has also always been important, but what we have been used to seeing is out the door, and we must make sure that we have no black holes of accounts that need to be worked but didn't. We must really watch out for payers who have an extraordinary change in volume outstanding, as this directly impacts our cash forecasting. And we must truly understand our productivity now more than ever, because the time and effort it is taking our staff to resolve accounts is growing right along with our inventory. We must be creative with our staff to leverage technology where we can to create efficiencies throughout our follow-up processes. Many practices cannot go out and double their staff size just to collect on the same patient population. So we must make sure our staff are getting to what they need to really drive cash. We cannot get behind and get in a backlog. And if you do, you will end up in an appeals vortex. So to compound the issues, we are not only loaded up on the to-dos that are now taking us longer to accomplish due to payer issues, but now you're also having to do more because we have less staff. Staff are doubling up on tasks, scrambling to not only learn these new roles, but to do so quickly and get everything done. And all of these things that we're doing now have even more of a critical impact to the success of our practices. Now, this sounds like a recipe for disaster, and it really can be if we're not managing it appropriately. So the odds may be stacked up against us, but revenue cycle professionals have existed in a narrow margin world where we do more with less for a long time. We're kind of used to these changes that challenge us. This is just one more change in our industry that never really stops changing. So we have to have staff who are in charge of all of the copying, all the records requests now, but also doing payment posting and probably some other stuff too. Really help them manage. We must create must-do work lists using the good old 80-20 rule to keep our staff focused and focus our attention on the things that will protect our practices in a good way and help decide the things that we're okay with having running backlogs on. So there are really 6 core tasks that we must do to keep this cash coming in. The first is billing. The idea being if you bill, they will pay. But I personally look at this more of a, if you don't bill, they won't pay. If you are not getting our claims out the door for the work our physicians and clinical staff are doing, we most certainly cannot expect a payer to pay for it. Second, just because you've hit the submit button does not mean the payers actually accepted that claim. We must also work edits and rejections to ensure that claims are truly accepted at the payers for processing. If you don't do number 2, depending on your claim clean rates and acceptance rates, you could be leaving big money on the table. Third, working that correspondence, responding to additional development requests such as documents, records, all of that in a timely manner, and utilizing technology as often as possible. Fourth is responding to denials and underpayments that should be appealed. Using your data to find those gross underpayments and incorrect denials quickly, determining which ones you actually need to work and getting those out the door. Fifth is posting payments. As I mentioned before, payment posting is just one of those things that allows so many other things to function efficiently. Payment posting on time helps you with your follow-up as well as your cash forecasting, and it is an imperative function. And last but in no way least, knowing your cash position at all times will help our leaders plan and strategize with a bit of clarity in these uncertain times. Now to issue number 5, appeals and underpayments. So do you see a theme here? Let's do more with less, but let's get it all done and do it well, typical revenue cycle stuff. People have less time to do their appeals, so they're coming to us. When people prioritize getting their bills out, they seem to not have enough time to put their time into appeals, and that's leaving money on the table. And to be honest, it's actually really difficult for practice staff to complete appeals remotely. Think of little things like how do you merge documents into a single PDF for a cohesive appeal upload? So again, we have to prioritize. In this case, practice number 5, prioritizing appeals and cash drivers. Now, what do I mean by this? The payers know their data. They know what providers appeal, they know which providers negotiate, and they know which providers barely get their claims in on time. Their access to this data gives them an edge. They also know when you're not appealing. If providers ignore claims that should be appealed, this can have a snowball effect. As payers see decreases in appeals to their denials, this raises their antenna. If those denials are, say, for something like missing medical records requests, well, maybe the provider's trying to hide something. I mean, obviously it couldn't be because we have a million things to do and no time to do them. This can cause an increase in records requests and really tank your bottom line if left unchecked. It is truly something that needs a lot of successful appeals and effort to turn around. If you simply cannot manage your appeals, you should outsource them to someone who can. And with that, I'm on issues number 6, which is preparing for reduced volumes. So one day we're open, the next one we're closed, then there's some sort of rule or guidance, and we're all struggling to implement these things. And it's really causing our volumes not to return to pre-pandemic levels in a lot of cases. Whatever the issue, whatever the day, we need to expect and prepare for the potential of reduced volumes. As Franklin mentioned before, some patients are simply putting off care, and some states are really not even open yet. If there's one thing 2020 has taught us, it is to expect the unexpected. Even as we reopen, we find some patients are still concerned with exposure and reluctant to return to the offices. And that brings me to my last best practice, number 6, maximizing reimbursements. Now, Franklin shared with us that many payers are making record profits. It is our job to ensure that those same payers are reimbursing you for what you were entitled to. What providers accept now as their reimbursement can have a devastating impact on their payments well after this pandemic is over. Making sure that claims are reimbursed what they should be will be a defining characteristic of practices who remain viable long-term. With lower volumes, missteps in the revenue cycle are magnified. Out-of-network providers must continue to leverage their knowledge on fair compensation for their procedures and ensure they are not treated unfairly by the payers. We must leverage every tool in our tool chest and work consistently, smartly, and with data on our side to keep our practices alive through this.
CollectRx has a game plan developed for providers that will help them through this maze of out-of-network collections during this turbulent period in our history, and just generally dealing in the out-of-network space. Insurance companies have all the leverage, making proper reimbursements difficult for providers. Our mission is simple: to level the playing field and drive improved care quality through increased reimbursements. These are the top 5 issues plaguing providers we talked to today. 5 to 10% of revenue is lost because of poor AR follow-up due to a lack of time and technology to support the effort. Whether it's in-network or out-of-network or Medicare or government claims, they are not properly appealed and therefore more money is left on the table. Christina has already talked about and described some of the choices we've had to make as our staffing has changed throughout this pandemic. And this is a place right here where, we have to figure out exactly how we want to approach and prioritize things. So CollectRx can be there to help you and support you in that decision if you do not have the staff to handle it. Number 3, and specifically for any out-of-network claims, 30 to 40% of revenue is lost on each claim because of the lack of data, time, and expertise to properly negotiate them. Let's face it, our billing systems are not robust enough to handle the collections process, so most providers resort to some type of spreadsheet or database support system that allow you to track your work by status and dollars and aging to augment what you have in your practice management system. If you're doing this, you might think you're doing a great job, but however, there are accounts that are slipping through the crack into that black hole that Christina talked about earlier. And then finally, providers are unable to properly manage their revenue without the proper key performance indicator. If you don't know where you are, then you can't really determine where you're going. So having these indicators in place certainly provides a direction of what to respond to, how to respond to it, and the urgency needed in order to correct that barrier that you're facing. All of these holes in payer collections can add up to gigantic losses in revenue for providers. Now, CollectRx provides a full suite of RCM services to help providers meet their financial goals and support them dealing with those top 5 concerns that I just talked about. With a focus on leaving maximum reimbursement, we handle revenue cycle times from coding and document review to patient payment processing. Our staff are experienced in out-of-network collections and recoupment, as many have transitioned from the payer processing side of the revenue cycle to the provider insurance collections. They've left the dark side and joined the good side. Another reason for our success is what we call our CRISIX Business Intelligence Engine. CRISIX stands for CollectRx Information System, the data and analytics tool we've created to counteract the payer's efforts to reduce payments on out-of-network bills. It allows us to analyze actual insurance policies throughout the country to determine what is reasonable and customary. Also, it provides us with an incredible amount of comparable data because we are aggregating this data and results from the 800 plus customers that we service. We use data and analytics to compare our determination of reasonable and customary with the payer, and in many cases, we're able to identify holes in their data and convince the payer to increase the payment to the provider. Our database captures business intelligence about the tendencies and trends to the people on the payer side. Our experienced teams knows who to speak with at each of these companies, and we have the ability to go to the senior personnel at the payer, who oftentimes are the only ones with the authority to approve higher payments to providers. So this is another look at our proprietary system. This is our proprietary data and analytics tool we've developed to maximize our out-of-network reimbursements. Our CRISIX software database aggregates data from multiple sources, providing visibility and insight into payer behavior. First of all, CollectRx analyzes policy language from insurance companies throughout the country, so we have a detailed understanding of plan types and language defining their usual and customary. For example, they may want to pay 110% of Medicare, but the actual policy will say reasonable and customary is what similar facilities in the community charge. So we don't just rely on what the insurance company is proposing to us. We go straight to the source and act accordingly. CRISIX also has an incredible amount of comparable case level data because we're aggregating that data and results from the customers that we've serviced. CRISIX also captures business intelligence about the tendencies and trends of the people on the insurance company side that we're speaking with, so we can leverage that knowledge when we are negotiating or appealing a specific case. So as we go through 2020, chances are you'll run into some of these trends in our out-of-network payer tactics. When you do, just remember that you have plenty of tools in your toolbox to combat them. The best way to combat them is to be prepared. I hope we've been able to provide some good information that you can use in your daily practice to ensure that you're being paid equitably by the payers in a timely manner and your claims aren't being denied unfairly. Out-of-network is a good strategy for many practices, and we hope we've been able to help you integrate it into your daily processes. So again, I'd like to thank everyone for joining us, and at this particular time, we'll have questions to answer.
All right, thank you, Franklin. All right, let's look at some of the questions we have coming in. The first one, how are you calculating your days to pay by payer? Great question. Well, there's so many ways you can accomplish this, really. Some systems now are actually automatically providing you with that information, and it's looking at your 835 and 837 submission data and comparing the two. If your system isn't already doing this for you, you can create this yourself by looking at some of your encounter level detail and finding when you're submitting claims, so your final bill date or the date that it is submitted to the payer, and kind of roughly comparing that to your date you're posting payments, as long as you don't have a large backlog in payment posting. So there's some easier ways you can do it if your systems aren't doing it. But obviously the easiest way is to let that technology work for you. And it has all, if you're got your 837s and 835 data in, you should be all set, and the system should be able to tell you both on a payer and even on an encounter or an account level. All right, next question. What is the best way to prioritize your follow-up? Well, that's a good question. Sometimes that feels like it's changing every day. Right now, it's just really important for us to understand what we can overturn. A lot of times you get kind of stuck in policies where I have to appeal this because it denied, and the policy says I have to appeal it. if that's an internal policy, if it's something like a no auth denial and you really didn't get an auth and you needed to, and sometimes now with COVID you can get around that, but if it's something that's been an issue forever at your practice and they're older claims, maybe now is not the time to focus on that, because you are throwing good money at bad. So you need to make sure what you're appealing and what you're working is actually winnable. And you don't want to burn through your equity with the payer. And what we mean by that is, at this time, now more than ever, the squeaky wheel doesn't always get the grace. That's not always how that works. They have a lot of data. They know what you're appealing. They know the providers that are just robot appealing things. They know the providers who, when they get an appeal, they better overturn that, because they know it's, 9 times out of 10, a very good, strong appeal. So they know that, and now's not the time to be the one that just appeals everything. The best way is really to use technology in your data. But if you don't have the data and the technology to really prioritize that for your staff automatically, you can do some manual reviews and really just determine what historically your allowables were by procedure, and then the total dollars per, share that against the total dollars you've received on your newer receivable to see if there's room for appeal there. So if you've always gotten $50,000 on this one procedure, and this claim came in and same payer plan, all of the information's the same, and now it's paying $25,000, maybe that's something you appeal. But you really have to look at what you were doing before and compare it to actual examples of what you're doing now. And you can use other resources like fair health data and things like that to really determine what you should be receiving for those.
So Christina, those were the 2 questions we had in the queue. I want to allow, if there are any other questions, we have a few minutes to answer those. If you would like to submit those, please do so. We'll wait here 30 seconds or so to see if we get any more questions.
It looks like we might have had one just come in. All right, medical records requests from United Healthcare. Sounds like someone's got a lot of those requests, and what is the strategy to proactively identify those lists of claims? Again, this is another thing that data can really help you with. There is some rhyme or reason. There can be a lot of different rhymes or reasons why United Healthcare, any payer really, has targeted something to request documentation on. Now, like I said before, if you're not appealing or you haven't been responding to records requests, that can flag them to send you more. It's one of the slippery slopes that all of a sudden you didn't have time to do them before, and now you have even more to do. So that can be one reason, or you can find that it's a specific procedure. There may be a specific patient plan that is requiring more information. A lot of times we typically see certain types of procedures or certain billed charge amounts being flagged for records. Now, if it's a specific type of procedure, it's really important that we not only look at what they're requesting, but also proactively making sure that if they have a policy, a specific policy for, making up an example here, but maybe there were some conservative treatments that had to happen before a surgery was done. Making sure that you have all of that ready, and using those portals to find those requests fast, and having that as part of your maybe claim submission process where you gather that for that one particular procedure. If you're using a billing company, make sure you send that stuff over to them as soon as you're sending your charge tickets or fee slips. Making sure that you can identify either it's a specific procedure or it's a specific dollar amount. There's something to it, and you can find that in your data. You just need to kind of data mine that out and figure out what it is that they're queuing in on, so that you can be prepared to send those records requests over. There's in the industry, some people say, drop those to paper and mail them in. Right now is not the time to do that. I've not really been a proponent of that even before COVID, but paper is like really not the issue or not the solution at this time. Use those portals, log into the portals, upload your stuff in the portals, send those claims electronically, because right now technology is the only thing that's getting a lot of our claims through the system, if you're mailing them in and someone's got to scan them, then you're really hoping that that payer has staff on site to do that.
Excellent.
All right. Do we have any other questions?
I think that's it. So thank you everyone for joining, and we hope that you found this information helpful. If we did not get to your question today or something comes up down the line, don't worry. We will reach out to you within the next business day to get your answer directly, get that answer to you directly. Again, thank you everyone for your time, and we hope that you enjoy the rest of your day. We look forward to having you on future webinars. Take care.